Good evening, everybody. Sorry for the delay. I fell asleep and I fell asleep and I woke up late. As usual, it always happens. I'm just gonna fix something. Oh, hello Archetype, hello Pat, hello Luis, Gamer, hello Abdul, hello Skypen, hello. Yes, hello, it's me, Emily. Hello, hello. Alright, keyboard is up. I don't know why. Okay. The keyboard is not working, so I don't know why. No, it's okay. I need the keyboard. I may need the keyboard. So I don't know why my keyboard is on. I set it on wireless and it's not typing down. I mean, is it not safe? Yeah. Okay, I don't know why my keyboard is whatever. That was doing some lots of work lately. Yeah, I just got sleepy every time you know how it is when you lie down in your bed and then you say, okay, I'm just gonna rest my eyes for like 3 minutes and end up sleeping a lot longer. That's what happened to me. I just ended up sleeping a lot longer than I was supposed to. Basically. Okay, you know what? I think I know where I'm gonna put this. I'm trying to get my keyboard. I don't know why it doesn't want to work. Place to put it. Me every time I took a break from studying. Yeah, this is what happened. That's what happened to me. Oh wait. There. Hello, mic test. Okay, is that better? I didn't realize the gain on my mic went down. Okay, how's that? Is the volume a lot better? Oh god, my keyboard still doesn't work. I don't understand why it doesn't want to work properly, my keyboard. Yeah, it doesn't want to work. Yep, my keyboard doesn't want to work. Okay, the wireless mode is not working for some stupid reason. Okay, anyway, whatever. We're gonna get started. We'll just get started in a bit. Let's try Bluetooth mode. Bluetooth mode will work. Bluetooth. Nope, it's not working. That's not working. Okay, fuck this. Let's just start. I've been unplugging and unplugging, okay? I'm trying to do wireless mode because you know why? I'm gonna use my tablet Anyway, whatever, we can do it. We'll just fix it next time. I'll just do wired mode. Bahala na to. There we go. I'm just gonna move it to the side here. Alright, let's get started. Okay, so I will be talking about a certain case today. So this is gastric outlet obstruction. This is actually the case of a patient that I'll be operating on in a while. No, in a few days, sometime this week. Okay. So this is like just like before, just like the thyroid case before. I will be presenting it in almost the same way, like a case presentation. Okay. Alright, let's go. Let's start. We can use the pen, by the way. Let's use I will prepare the pen. Alright, so we have a very old patient, a male who lives in Manila. So that's the patient data. Okay, here's a little his history. Okay, so his chief complaint is vomiting. So actually, this patient has been having on and off episodes of epigastric pain for the past year. Epigastric is like an area in the abdomen that's like in the upper middle part, a little below the middle of your rib cage. That would be the epigastric area. Okay. So 1 week prior to consult, 1 week before he consulted, he had epigastric pain again, which he described as crampy. Okay. And then he would have vomiting episodes after eating a meal. Like, almost immediately after, actually. Or probably almost immediately to like a few minutes after eating something, he would vomit. Okay. He had no changes in his bowel movement, so, he had no bloody stools, or, you know, when you defecate, it wasn't bloody, it was just brown. No, so hematochezia is the medical term for bloody stools. He had no melena. Melena is the medical term for dark or black tarry stools. So they're really, really black and dark. He had no hematemesis, which is bloody vomiting. Okay. So none of that. He just had abdominal pain and then vomiting right after eating. Okay. So persistence of this prompted consult to the ER. Actually, he went to the ER. What content of vomit? Oh, it's postprandial. Whatever he ate, that's what it was. Whatever he ate, because he vomited. He vomits almost immediately after he eats. So whatever he ate, that's what he would vomit out. Okay. So, review of systems was unremarkable. His past medical history is also unremarkable. He had no other illnesses and no previous surgeries. His family history also, no history of anything, any remarkable illnesses. His personal and social history, so he used to smoke like 20 sticks a day. And then he's a non-alcoholic beverage drinker and he denies illicit drug use. So yeah. So on physical examination, there's this is very brief, okay? I didn't do a really detailed one. I just so it's like a really quick physical exam. So, he has no palpable neck masses. His lungs are clear when you auscultate them. Heart sounds are clear, distinct. The rate is regular and the rhythm is also regular. No other abnormal sounds or murmurs. Okay. His abdomen is flat, slightly distended. Okay, slightly distended, but it is soft in palpation. It is non-tender, so no pain when feeling it. And there's no palpable masses. Okay, no palpable masses. Can't feel anything. Okay. Is it empty rectum? Okay, I'll add. I forgot to put that. That's a very good question. We did a digital rectal exam. Okay, digital rectal exam was his anal sphincter tone was he had a good anal sphincter tone. Okay, there were no palpable masses. There was no blood in the examining finger. There was stool though, like brown stool. But then nothing, rectal vault is not collapsed. It's just normal. Nothing abnormal in the digital rectal exam. Okay. So, what's my primary impression? Okay, initially, this guy looks like a case of probably acid peptic ulcer disease, which is basically the medical term for, having hyperacidity. You know how yung nangangasim or parang acidic yung feeling ng tiyan? That's basically it. Acid peptic ulcer disease. Differentials, other stuff I would think about, it probably has cholecystolithiasis or gallstones. And other than that, probably a gastric outlet obstruction caused by a mass, but I didn't feel any. Okay. Anyway, let me draw something for you guys, okay? Oh. Draw it properly. Okay. This is a very ugly drawing of the abdomen for me, okay? So you can imagine this part is like the ribs, okay? So I'm gonna like divide the can we change the color of the pens? Let's do it blue. Okay. Imagine that this is your abdomen, okay? And then we're gonna divide it into 4. So this is how we divide the abdomen, okay? When you say this up here is the right upper quadrant, okay? This is the left upper quadrant. This is the right lower quadrant, and this is the left lower quadrant. Okay? Over here, in this area over here, this area here is the epigastric area. Okay, epigastric. That's why if you have pain here, you'd say, oh, pain on the epigastric area. If you have pain here, like in this quadrant here, it would be the right upper quadrant area. And if it's here, it's the left upper quadrant. And then the right lower quadrant here, left lower quadrant. Over here, if you go down here, this would be the hypogastric area. Hypogastric area. Okay, those are the areas of the abdomen in general. Okay? Just so you know. So why did I consider cholecystolithiasis? Usually when you have gallstones, the pain is here on the right upper quadrant. But sometimes the pain could also be on the epigastric area. So it could also, because it's actually within it, see? Like the right side of the epigastric area is also part of the right lower quadrant. That's why I thought of that. And it's a very common disease. You know, if people complain about abdominal pain, and it's up there, you gotta rule out gallstones because it's a very common disease. Okay. What is the bowel cells? The bowel cells are normal active. Vital signs are stable. Okay. Okay. So, why did I consider gastric outlet obstruction? Because he would vomit whatever he ate. Okay. Although on my physical examination, I didn't feel any masses, so yeah. Alright? So that's the rationale behind my impression. What's causing gallstones again? Usually it's a diet, if you want, cholesterol stones, but that's the usual cause. It's a diet. There's different kinds of stones. Usually it's caused by diet when you have when you eat fatty foods. Okay. Alright, next, go to the next slide. Okay, why is it not? Okay, here we go. Alright, a CT scan was done. Okay, we ordered for a CT scan. So we did a CT scan of the whole abdomen with an IV and oral contrast. And these are the pertinent findings, okay? The important findings in the scan. So the stomach and the first part of the duodenum. So stomach and first part of the duodenum are markedly dilated and have retained contrast. There is abrupt tapering and collapse of the second and third parts of the duodenum, and there is no passage of oral contrast past the proximal and second part of the duodenum. Okay, let's I'm gonna draw that for you guys, okay? Let's draw a stomach here. I'm gonna draw a stomach. You imagine that this is your stomach. Stomach! This is a stomach. Okay. And then the stomach would sometimes go like this. When it becomes a small intestine, there we go, like that. And like that. Ha! I drew a really nice stomach. Okay? So, this part here is the stomach, okay? This would be over here, the pylorus. This is like the end of the stomach, which enters into the small intestine. So this right here is the duodenum. The first part of the small intestines is the duodenum. Okay? So you guys gotta know the anatomy. There are the small intestines. Small intestines has 3 types, okay? Small intestine. You have 3 parts of the small intestine. So the first one is the duodenum. Duodenum. Second is the jejunum. Jejunum. And the third is the ileum. Okay? So this part over here is the duodenum. And you have like, this is like the first part, second part, third. And there's also a fourth. This one actually goes up a little like this. Fourth part. Okay? So you have like a markedly dilated stomach with retained contrast. So the stomach was actually quite large according to the CT scan. So let's get it right here. The stomach was actually quite large, so dilated, so it was actually large. As long as including the first part, so it's like a little larger like that. Okay. And then it tapers, and then there was collapse, so it like becomes like this. Collapses into like that. Something like that. It tapers, it just suddenly constricts here. Okay, and then probably there. Get what I mean? Dude. Duodenum. Ooh. Duodenum. The duodenum. Bruh. Okay, so there was like a constriction. But the CT scan, actually, interestingly, the CT scan would say there was a constriction. It would say something like that. That's how the CT scan described it. There's a constriction here. But it didn't say there was a mass or anything. Okay, so it just said there's a constriction. Can an enlarged stomach cause pressure on the gallbladder? No, not really, because the gallbladder would be a little further. Gallbladder would be like somewhere here, in this area. It's far. Okay. I'm gonna look for. Let me look for an image of a stomach that we can that I can show off here. Hold on. Let's see. I'm gonna look for a stomach anatomy so you guys can see. There we go. This is a very good photo of the stomach with this one. No, that's an ugly photo. Wait, hold on. Okay, I'm gonna look for this one. Okay. Alright, we're gonna... I am going to show you... Hold on. There we go. Okay, so... Oh, it's a little covered, but yeah, here, you can see the stomach here. Oh, how do can I just... Here on the right side. There we go, that's better. So, yeah, you can see, right? This is the stomach, and then it's like I drew, like the letter C, the small intestine, there's a letter C. Okay? That's basically how the stomach looks like in your body, and then there's like a constriction over, over here. Okay. Okay, let's go back to my slide. There we go. Alright. Okay, so after seeing those CT scan findings, we referred the patient to gastroenterology and we had an endoscopy done, okay? So what is an endoscopy? It's or an EGD or a gastroscopy. So it's when they place they put you to sleep and then they use a scope, a camera, like a tubular camera that they insert through your mouth, and it goes down through to your esophagus and into the stomach and into the small intestines. Okay, so that's what we did. And this is what their findings were. Okay, they found a complete obstruction. Okay, complete obstruction of the pyloric opening. So the distal part of the stomach had a complete obstruction. The surrounding mucosa appeared nodular with ulcerations. There was retained secretions approximately 250 ml, and then they took biopsies. So, let's let me draw the stomach again, okay? Okay, there. Okay, so there was obstruction of the pyloric opening. So the pylorus is somewhere here. Yeah. So there was obstruction here. So when the scope went down, they used a scope to see, and then Usually the scope would like go through here and then all the way to the small intestine. But he saw an obstruction. There was something blocking the way. So he couldn't go any further than that. Okay? And the surrounding mucosa appeared nodular with ulcerations. So he called it, basically the gastroenterologist called it as a mass. Okay? And he took biopsies of this area. Right? So after that, biopsies were taken, and the result of the biopsy was a tubular adenoma. Okay? And then a background of severe chronic inflammation. Tubular adenoma. So, what is tubular adenoma? It's actually like a abnormal dysplasia of the tissues. It's like a mass, but it can be precancerous. Actually, if it's a tubular adenoma, there's like only less than 10% of it becoming cancer, or upstaging into cancer. Less than 10%. Okay. So now that we know this, what is the surgical plan? Okay. So this patient is an old patient. Okay, he's really old. He's like in the extremes of age. He has an obstruction. Okay, we were actually, when the CT scan said that there was like a constriction going on there in his intestine, we were highly considering that maybe there's a mass, because when you think about an old person and there's like obstruction going on, you'd think of a mass. Usually, you would lean towards cancer. Usually would lean towards cancer, okay? And so that's why after the CT scan, we had him referred to gastroenterology, and we had to have a scope, endoscopy done, and then biopsy. Because an endoscopy is more accurate in a sense, because it's like, direct visualization. It can see things CT scan can't see. So the CT scan couldn't see a mass. It just showed us a constriction. The EGD or the endoscopy said, oh, there is a mass here causing the constriction, and then took biopsies, and what came out was not really exactly cancer, but tubular adenoma. So, what is the surgical plan? Okay, let me see. Someone here says resection, another one says stent or balloon. Okay. Actually, the plan is to resect. Okay? We have to remove it. Whether it's cancer or not, okay? Whether it's cancer or not, we have to remove that because he can't eat, alright? He's having trouble eating already. Every time he eats, he vomits because, there's an obstruction. So, even if the mass is non-cancerous, we still have to take that out. Okay? We just have to remove that. We have to remove that, and, we gotta rearrange his bowels, basically. So the plan is to resect. Distal gastrectomy. Okay? Oh, my head is blocking. Wait, let me move myself. My head is blocking the slides. Hold on. There we go. Is that better? I am blocking the... There, I think that's better. Okay, wait, I'll take my... I think that's okay. Alright. So let me draw the stomach again. Oh. So we know that the mass is here, right? So what we're gonna do is a distal gastrectomy. So distal, here we go. Probably there will be an extension. This is a distal gastrectomy. Okay? There will be a little extension here. The dashed lines indicate where you're gonna cut. Like, for example, here in the proximal, you start here, you cut here, here. In our case, we're gonna do a subtotal or a distal gastrectomy. Subtotal or distal, okay? But most likely it's a distal. So distal is where you cut here. And we'll probably go beyond this margin here. We'll probably like cut a little lower. Because the mass on this patient is, the tumor is right there. So you don't want to cut there. You want to cut a little beyond. Okay? We cannot do a wedge resection. So a wedge resection is when you remove like a part of the stomach, like a small part, like this. So we cannot, if the mass is here, you cannot just remove this, like a really small part, just that. Okay? No. We have to have our margins. Why? Because even if this guy, see, the biopsy came out as not cancer, we are still very highly considering that it probably is cancer, and that the tissue biopsies wasn't really exactly adequate. Okay? He has a tubular adenoma, which is like a 10% chance of converting into cancer. Sometimes when you get a biopsy that is like on the edge of the tumor, the edge like here, it would come out as negative, and it would just get like chronic inflammation. But if you get a biopsy from the center of the tumor, it'll usually come out as positive for cancer. In this case, it was just so, it obstructed that the scope couldn't go any deeper, so they could only take like the edge. Okay, so this is an example of having a high, what do you call this? Index of suspicion or something like that. You know how they say sometimes when you, especially for those in the medical field, you know how they say, you get diagnostics and they say, you have to compare to your clinical findings or your clinical findings, like your history in PE. So we have this high index suspicion of cancer, despite having the diagnostics tell us, oh, this is just like tubular adenoma. Probably isn't, but when you have something like this, a mass constricting like a part of your bowels, most probably the most common that we always see, it is cancer. Okay, so we're gonna be treating this guy as if it was a cancer surgery. That's why we can't just do a wedge resection. We gotta have our margins. We gotta make sure that the margins are adequate. Okay, margins meaning you have to give a little space of like normal tissue, because you never know that there might be little cancer cells that are there, and then if you cut it a little too close to the main tumor here, you might leave some cancer cells, and it, the tumor will just recur. That's why there's margins. Okay, so that's why we're gonna do a distal gastrectomy and not a wedge resection. Nope. Not wedge resection. It's either distal or subtotal. So subtotal is like almost the entire stomach, but you leave like a small part. Okay. Depending on the mass that's here, if the mass when on the time of the surgery, if the mass is like a little more extensive, like for example it extended here, then you probably might do a subtotal, because just to get the adequate, good enough margins. Okay? Total gastrectomy is when you remove the entire stomach. I don't think I've ever done this one before. But that would be like, really severe cases. Central is another one. But this is kind of like wedge resection in a way, because you're only removing like a small part of the stomach. Okay. Mass is sus. That looks like it hurts. He'll be asleep, so he won't feel anything. Distal gastric resection with jejunostomy feeding. Jejunostomy feeding, probably. Like, temporarily. Okay? So, yes. For this patient, we're gonna remove part of the stomach. Okay, so we're gonna cut here and here. Here. Cut here. Cut part of them. Distal done to preserve the gastric. Yeah, you have to leave like part of the stomach. You know, you don't want to remove the entire stomach. You gotta leave some. As much as if you can leave part of his stomach there, then do it. Just so that he would, you know, still have like the function, and he could take advantage. His body could still take advantage of like the function of the stomach. Okay. So next, gastrojejunostomy. So, if we're gonna remove part of the stomach, we have to, you know, reconnect it somehow. Yeah? If we're gonna remove part of the stomach, we have to reconnect it somehow. So let's say we're gonna remove this part. This is gonna be closed, right? This will be like sealed up when we this is gonna be sealed up, and also this part, the distal part. So this is the part that's going to be removed. Now what's gonna happen? Like of course you can't just remove the, you know, you can't just remove that and then, you know, say you're done for the day. You gotta reconnect the stomach to the small intestine somehow. So, this is why we have gastrojejunostomy. There's also another case where you do gastroduodenostomy. Okay? Gastroduodenostomy. So this is when you connect the remaining stomach to the duodenum. So here, look, you can see right here, duodenum. When you connect this remaining part of the stomach, here, this one, to the duodenum. But what we're gonna do is connect the remaining part of the stomach to the jejunum instead of the duodenum. So it's gonna look like this over here on the right side. So you get like a loop of the jejunum, you raise it up, and then connect it to the remaining part of the stomach. And this part, the duodenum, remains closed. Okay? There's like a proper term for this. So gastroduodenostomy is called a Billroth 1. And a gastrojejunostomy is called a Billroth 2. Billroth 2. Okay. Alright, so we're gonna be doing a Billroth 2. Now, why not a gastroduodenostomy? There is a difference. Gastroduodenostomy is actually more difficult to do than a gastrojejunostomy. Why is it more difficult to do? Because look at this. This is the pancreas, the yellow one. It has ducts attached to it, okay? You have a duct there. You have to free this part. And then when you connect it, you have to make sure you don't, you know, injure this. There's a lot of structures there. So, it makes it a little more challenging. But as far as I know, Japan is, I think, if I remember correctly, Japan is very pro at Billroth 1. Japan. I think, if I remember correctly, they are like freaking pro at the gastroduodenostomies. I think they do this one more. And then like in Western or here in the Philippines, it's a Billroth 2. We are Western. We're not based in Japan. We are Western. But you know, either way, you know, it's they have their advantages and disadvantages. But The point is you just gotta reconnect the stomach to the small intestine. Okay, you can choose to do a Billroth 1 or you can choose to do a Billroth 2. So in our case, we're gonna be doing a Billroth 2. Okay? So we'll do a gastroduodenal like they do in Japan. It's really more like a, you know, preference. So, to be honest, in my training, I have not seen this that much. So the most commonly done here is a gastrojejunostomy or a Billroth 2. So probably if I trained in Japan, I'd probably see more of this. Challenging one. Japan, a lot of stomach cancer. Yes, actually. Japan has a lot of cases of stomach cancer, so that would explain why they're really pro at the harder one. At this one. Okay? Alright. So that's what we're gonna do. Gastrojejunostomy. So what happens is you just get a loop of the jejunum, you're gonna reattach it to the stomach. The duodenum remains closed, so it's just gonna be like a little loop, floating loop there. But you still maintain the, the function. The ducts are still there, they will still produce the pancreatic juice. The bile will still be going here. And it'll just flow, okay, and mix up with the whatever you eat. Okay. Next. Oh, here we go. Here it is. I forgot I put this slide. Here we go. Differences: the Billroth 1, Billroth 2, and there's also the Rowan Y. Look at this. It's like this is just like what do you call this? Reconnecting pipes or something. So Billroth 1, this is Billroth 1. The first one is Billroth 1. So this is the duodenum. You just reconnect it to the stomach. Okay, this is the duodenum here. Alright, so this is the food. It just goes there like that. Okay. This one is Billroth 2 or gastrojejunostomy, which we will be doing. So part of the stomach is just connected to a loop of jejunum over here. Over here. This is the duodenum. Okay, so the food particles like that. Right? Now we have here a Billroth 2. We have a gastrojejunostomy Rowan Y. So here, it's pretty much the same except that you're gonna cut the duodenum and reconnect it a little further over here. So jejunum attached to the stomach. So you're gonna just separate it from the duodenum and then you just reconnect the duodenum here and further away from this one. So it looks like a letter Y, a Rowan Y. Okay. What is the difference between Billroth 1 and 2? Gastroduodenostomy for Billroth 1. Gastroduodenostomy. Billroth 2 is gastrojejunostomy. So yeah, basically from the name itself. Okay. Connect the stomach to the duodenum, that's Billroth 1. Connect the stomach to the jejunum, that's Billroth 2. Alright? And then there's this one, Rowan Y gastric bypass. So this one is for unresectable tumors. So you can see that the stomach is still there. Okay? Stomach is still there. Probably can't be resected, but what you're gonna do is like connect the bowel to the functional part of the stomach or away from the tumor. So here. It looks almost just like this one, except that you just see the stomach there. Okay? So there's like many ways you can reconnect the bowels. Okay? So, most likely we'll be doing this one. Billroth 2 is the most likely one. Okay. D is for palliative. Yeah, D is for palliative. Like if if you are like doing a surgery, for example, we're doing his surgery. Our plan is to do a resection and then gastrojejunostomy. But if we see that the tumor is unresectable, let's say the tumor is so big that it's invading into major vessels and you really can't resect it, then we can actually convert from, instead of doing their gastrojejunostomy or our Billroth 2, we can just do a gastric bypass. So like the final decision on what you're going on the final procedure that you're gonna do, it really depends on what you see once you open up the patient. So I can say, okay, our plan is to do a distal gastrectomy, gastrojejunostomy. But if we open up the patient, we see, oh no, it's unresectable. We can't take out the tumor. Okay, what's the next? What do we gotta do? We have to have a plan B. So the plan B would be like a bypass, because our goal is to be able for the patient to feed normally through mouth. So if you do the bypass, you still maintain, or you can still have the patient eat like a normal person through his mouth. Let's say the whole stomach is deceased, okay? If the whole stomach is deceased, what is the option? What if he can't do a bypass because the tumor is just so bad? There's a lot of shit going on, he can't do it, and if he eats by mouth, he just vomits it out. How is he gonna eat? That's when you do a feeding jejunostomy. Okay, the other option is a feeding jejunostomy. So feeding jejunostomy is when you get a loop of bowel, like a jejunum here, and then you just insert a tube. And the tube is where he will feed. Yeah, you can't have the patient stay on TPN forever. TPN is very expensive, by the way. So this patient has been on TPN. I was able to get him, jumpstart him, like the first bag I was able to get for him from the donations you guys gave, and then the rest they were able to buy on their own. So they were able to get some money, but it's really, the TPN is really draining their funds. That's why I had to help them some more. Okay, so hope you guys understand that. Right, next. What is this? Next, lymphadenectomy. This is for cancer surgery, okay? So lymphadenectomy is when you remove lymph nodes. Removing lymph nodes. So this one's a little bit challenging. There are two lymphadenectomies for stomach cancer, which is a D1 and D2. So you see these numbers here? 1, 2, 3, 4, 5. Those are the areas of the lymph nodes. So if you remove lymph nodes from here, 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 all these numbers, that is a D1. So that's like station 1, 2, 3, 4 until station 6. Okay, that is a D1. So stations 1 to 6. A D2 is extended, so it includes like 7 all the way until station 14. Here's 14. So station 1 to 14. That's a D2. This is what you do this for. You do this one when it's a cancer surgery. So initially we were thinking, do we have to do lymphadenectomy on this guy? Because we're not sure if it's cancer. His biopsy didn't come out as cancer. But I have a feeling that once we open up the patient and the tumor itself looks like it's cancer, we're probably gonna be doing this. Okay, I have a feeling we'll be doing a D2. Okay. So, this is actually kind of complicated. Even, what do you call this? It's, you know, the lymph node stations of the stomach, there's, like, a lot. So, yeah. Didn't know all that. Alright? Okay. So, there is a high chance that we'll be doing a lymphadenectomy on this patient as well. Now, so useful. Yeah. What is this? Okay, so, knowing all this, okay, we have so knowing all of this, like, let's go back. Okay? We have a really old patient. We have to resect like almost half of his stomach and then reconnect. So we're gonna like close this up. Like I said, you have to close up the duodenum and then you're gonna have to connect it. Okay, you see these areas? Let's I think it's better here. Okay, here. Let's look at Billroth 2, okay? Let's use a red ink. I'm gonna use red ink this time. Red. Alright. Okay, guys. You see this part over here? So this one, this is a wound, right? Because you separated it from the stomach. That is a wound. This one is also a wound because you just suture it together. Especially over here. This over here. You see this? The attachment. We call this an anastomosis. When you reconnect something, it's called when you anastomose something. So over here, this is an anastomosis. This one is also an anastomosis. Okay? It's called an anastomosis. So these parts, these things, if are very prone, okay, this red stuff, the anastomosis and the areas that you close over here are very prone to leaking. There's another one here. Very prone to leaking. Post-operatively, like after the surgery. So, here, this one also. Okay. These are very prone to leaking. Okay? Because these are why? These are wounds. So, this patient, what makes this challenging is because one, his age, he's really old. So, you know, when you have an old patient, the immunity, you know, the overall body is it's weaker than a younger person, okay? Immunity is lower than that of a younger person. So, he will have, he is high risk for getting leaks. And leaks, anastomotic leaks, okay? Anastomotic leaks are a disaster, actually. Anastomotic leaks. Hello, Raphael. Thank you for the sub. Anastomotic leaks, okay, are a surgeon's nightmare. This is a nightmare, okay? Nightmare. You don't want this to happen. Definitely don't want this to happen because once you have a leak, what do you mean by leak? Like, for example, this opens, okay? It opens. So anything he eats just spills off. It just spills around in his abdomen. A lot of the time, an anastomotic leak would be a surgical abdomen. And what would happen? You would need to reoperate on the patient. Which is bad for him because he's old and you'd be subjecting him again to, you know, another major surgery. So, that's why in cases like this, nutrition is very important. That's why he's been on TPN for quite a while, and TPN is very expensive. And I was able to jumpstart him on his TPN using our dono funds because he is unable to eat, so he needs the nutrition. Luckily, his relatives were able to buy some, but it's really depleting their funds. So I'm just there watching his nutrition and making sure that he's getting it. Okay? Yes, it's risky, but he needs it. Okay, he needs it because we need to take that tumor out. So preoperatively, I am building him up with TPN. And yeah. Okay. That's what makes this surgery a lot more challenging, because it's not just intraoperatively, but also, you know, preoperatively, before the surgery, during the surgery, and after the surgery. I really need to watch him. Okay? And this is why I was able, this is why I if you saw my tweet, I posted a tweet earlier this afternoon saying that I was able to get him some linear staplers or linear cutters. Okay? I'll explain why. I'll explain why right now. Okay? So, let's use purple. Okay. A linear stapler or a linear cutter. Okay? So, how does it work? How does a linear cutter work? So, what you do is, for example, I need to look for it. Let's see. Let's go back here. How does a linear cutter work? Okay, if you don't have a stapler or a linear stapler, if you don't have one, okay, you see, if we didn't have a stapler, how would this close? Like, how would we close this, right? How would we close this? How would we close this? If we didn't have the stapler, we would have to do it by hand. So, suturing, right? Suturing this closed and this and anastomoting that by hand takes a while. Okay? It takes a while, and it takes longer because you have to be very precise, and you have to make sure that you are suturing the edges properly. Good spacing. Good spacing. You gotta make sure you got the whole thickness of the bowel. Alright? So it's gonna be by hand. Now if you have a stapler, you know what you do? All you gotta do is just put this part of the bowel here in the stapler. Say this is the stapler. Look like that. Stapler. Look like this. All you gotta do is that. Okay, stapler, and then just slide it. Once you slide the stapler, it will cut the bowel, and at the same time, it will staple it close. Right? So once you remove the stapler, this whole thing, this part is closed. It's sealed. Sealed by stapler. So it's that fast. You just do a little swipe and it just cuts the bowel and it's stapled already. Unlike when you do it by hand, where you have to cut it and then you have to manually suture this. I don't know, 30 minutes or 15 minutes, depends on how good you are. And then you have to cut this part too, right? You just put the stapler in like that. It looks like a little handle like this. And then just slide it. There's like a little slider. You slide it, it'll instantly cut this, and it'll be closed. And you can just remove this part. Right? So you have this sealed up and this sealed up. And then what's left for you to do is to get the loop of the jejunum and reattach it to the stomach. Right? That's it, actually. And that part where you reattach, you can do that by hand sewing already, because this time, at least, you just need to make a small hole. You make a smaller hole here, and then, you can just make a little hole, and then reattach the stomach, the bowel there, and just hand suture it. It saves a lot of time, Because you don't need to like hand suture this closed anymore. You don't need to hand suture this. You just use a stapler and you're good. Okay? It saves up a lot of time. So that's why I got that stapler that you saw on Twitter. Because for this guy, I really think he needs it. He will benefit from it. Especially that it'll shorten the OR time. Okay. Do patients feel them later? No, not really. They won't feel it. How long till they get to take solids again? Oh, they will be after the surgery. He needs to. There's a bowel rest. You can't feed them right away because you gotta give time for this to heal, for the wounds to heal, the anastomosis. Okay, you gotta give time for these to heal. Because if you feed them right away, you might damage the anastomosis and it might cause leaks. So, how long? Around 4 to 5 days. 4 to 5 days of not taking anything by mouth. So, 4 to 5 days. Usually after the 4th day, if he's okay, abdomen is not painful, we can start him on clear liquids or like water, and then if he tolerates that, then the next day we can progress him to like general liquids, until eventually he'll get into solids. Okay, so like this is the golden day, the golden day, the 4th day. So he has to get through the first 4 days without any leaks. Then he's good. Okay. So, here we go. Complications. There are a lot of complications. This is like syndromes, like after surgery. Okay, after the gastric surgery. So we have chronic gastritis. That's kind of self-explanatory. You just have like gastritis. Forever have gastritis. Like vomiting, abdominal pain, but then nothing really surgical. Biliary reflux is when the bile goes back. Like I think there's a here we go. I think it was here we go. This one had this Billroth one perfectly just shows it. Look at this. See this part? This right here. This is the common bile duct, and it's inserting into the small intestine. So sometimes, because the stomach doesn't have the pylorus anymore, the pylorus or the, is there another image of the stomach here? Anatomy. Okay, here, this is larger. The pylorus is here, right? The pylorus helps, control the flow of food of the stomach into the small intestine and prevents backflow, right? It's like a little valve. So over here, since you remove the pylorus is gone. You don't have that little valve anymore. Sometimes the bile can just backflow into the stomach like that. So the bile, instead of going down here, will just go back. So that's where you have biliary reflux. Okay, you'd have like bilious vomiting, abdominal pains, and all that. Okay. So yeah. And then there is dumping syndrome. Okay, this one is a common one. Okay. There is early and late. Yes, Tanupat says it. Hold on, I will I think if I remember correctly, there's like a little flow chart on Google. I forgot to put it on here. Dumping syndrome. If I remember correctly, there's like a little flow chart for that. Aha, here we go. What is that? There is a flow chart showing like dumping. Okay. Oh, here it is. Okay. Let's open this in another image in the tab. Here we go. Oh, it's so tiny. It's so tiny. Okay, I don't know if you guys can see that. Wait. All right. Let me show you guys. It's so small. I don't know if you can see it. Wait. There we go. Dumping syndrome. So basically, what is dumping syndrome? It's when the food goes it goes very rapidly from the stomach into the intestine, because that's why you don't have the pylorus anymore to like control things. So what happens is when you eat something, it just goes from the stomach straight into your intestines. You would call that dumping syndrome. There. It's called rapid gastric emptying. Okay. So over here is like the pathophysiology of how it goes. So, if you have rapid gastric emptying, like the food doesn't digest properly, basically, and it just goes down really pretty quickly. And yes, you would have diarrhea. Okay. It can cause diarrhea. You would feel bloated. You would have pain, of course. And yes, hypoglycemia, you're right. Meow. Yes, I know you're Meow. Meow's got it. Okay, there's like a little table there. Okay. Okay, I'm gonna go back to the window. There we go. Okay. Afferent loop syndrome. Afferent loop and afferent loop. This is basically obstruction of the loops. Let me draw. Let's draw the anastomosis. So let's say this is stomach, and then we have a little. This is the stomach. It's been sealed off, and then we have the duodenum. It's sealed like this. Let's say there. This is the duodenum. This is the jejunum. When you say afferent loop is this one. This is the afferent loop. This one is the afferent. Afferent. And after this is our basis is this one, okay? This is the afferent loop. This one is the efferent loop. Efferent. So basically, afferent loop syndrome is if there's an obstruction. So if there's an obstruction here, like say this constricted, or let's say there's a constriction over here, this dilates. Okay? So there would be abdominal pain, sometimes there would be leak. Sometimes this could burst because of the dilation. Like whatever's in here, the bile, or the duodenal, the intestinal juices could just pile up and it couldn't go through, and it just leaks out here. Afferent loop is an obstruction on this part, which is actually rare. Like, for example, he suddenly has a stricture here, and then this just dilates. And what happens is, there would be a backflow. Okay? So, it's actually rare. Duodenal stump blowout. So, yeah, afferent loops, when I say this one, when there's a leak here on the duodenal stump, this is a duodenum, right? Over here. That would be the duodenal stump blowout when it starts leaking. Because there's an obstruction distally or anything, or the juices or the bile or they are unable to pass through here to go straight into the jejunum. So they just stay there, and then it just causes this to explode or blow out. Okay? Okay, those are the complications we gotta watch out for. So, that's why this is a very challenging surgery. I think this is my last slide. Yep, that is my last slide. So, you guys got any questions? So this patient is going to... this patient is actually going to will be benefiting from the donations, the leftover donations. I've already got the stapler. If you saw from my Twitter feed, let me show you. I'm gonna show you how that stapler works. So, hold on. Let's see if I can find YouTube. Linear stapler surgery. Is there like a way to show this? Okay, is there like a way to show this that would work or something? Okay, hold on. I am looking. Oh, is this it? I want to show you guys how the stapler works, but I'm trying to look for a video. And I can't find the one. Oh, is this one? I think I found one. Oh my god. Okay, I just got like a freaking ad! An ad! Okay. Okay, I found a video. But I think this is like, it's a Shanghai video! This. Look, this is how the stapler works. There, this is it. You just swipe it just like that, right? Okay. There, see? That's how it's gonna look, okay? See, that's how quick and easy it is. Okay? That's how quick and easy that was. Okay? That's how it works. So it's literally you just put the bowel into the stapler, swipe it, and it cuts the bowel and it seals it up. That's how quick it is. Compared to like hand suturing everything. You know, cutting and suturing everything. It cuts the time by a lot, significantly. Okay? In surgery and anesthesiology times everything. Yes, well, especially for this patient, he will benefit from it greatly. Because I don't wanna, you know, he's already gonna undergo a really major surgery, and we gotta do as much as possible to reduce the stress. How can we avoid this complication? Okay. One of the most common complication is dumping syndrome, right? So one of the ways to... these people who undergo gastric surgeries are very prone to that. So what you have to advise the patient to eat slowly and in small frequent meals. Like, they can't eat big meals at a time. They can't eat fast. They have to eat slowly or at small portions. So we would be like, eat small portions at a time. You can probably eat like more frequently, but small portions. Okay, don't eat too fast, and don't eat big portions. Like, instead of having like 3 meals a day, you probably have to do it like 6 meals, but small meals, something like that. Will we be leaving a drain? Yes, I will definitely be leaving a drain on this patient because of all the anastomosis that he's gonna be having. Okay, he definitely needs a drain. So that I can monitor any leaks. We gotta monitor for leaks, okay? Not exactly related to the surgery, but do you have any recommendations for food to maintain stomach health? Food to maintain stomach health. Just eat healthy, really. Vegetables. You know how, you have to have a balanced diet. That's basically it, actually. Having too much, meat increases your chance of cancer. You have to have a fiber in your diet and vegetables. Eat a balanced diet. Okay. Easy to digest food. Yeah. Something like that. Or, just eat, like, for patients who have, after gastrectomy, right? You just have to eat small portions. Okay? Snacking. Yeah, pretty much snacking. Or like having, just dividing the meal into smaller ones. Okay? I'm gonna drink. I have seen some laparoscopic surgery. They use some gel to decrease anti-adhesion. Does it really work? Some professor not remember. Right. Oh, okay. That is expensive. I know what that is. I have not used it because that shit's expensive. I have not used it yet. Okay. But according to the ones who endorse it, then it works. But of course, there's like studies done to show that it works. But I haven't really used it because that is expensive. Is the patient ambulatory? Yeah, the patient's ambulatory. He's like a pretty strong old man, and hopefully he stays strong. Okay, I don't know how he's gonna be after the surgery. No cake to celebrate. Cake? No, not after the surgery, man. He has to rest his bowels first. He can have water after 4 days. Okay. Any more questions? Because if there's no other questions, I would have wanted to give you guys a quiz, but I don't think we'll have a quiz for this one, because this one is more of a case presentation about a patient that I'm gonna do surgery on. Can we diagnose this disease from abdominal fluid, like X-ray? You can in an X-ray you'll probably be able to see that there's an obstruction, but then that's it. You'd still need to do more. You'll probably see like a dilated stomach, and then that's it. I think you forgot to check the homework. That's okay. No homework this time. Maybe in the next medical education stream. Yeah. I've been to many conferences before. It's quite odd of one of them's now from a VTuber. Yeah, I know. Conferences can be very bloody sometimes. I mean, I've been to many, and I've seen how other attendings berate their residents. I have been through that too. It can be very bloody. My mom became like that after surgery. She eats more frequently but small amounts. But she also has to choose what to eat, because in the past, a small rambutan clogged where she had surgery. Oh, yeah, you do have to watch what you eat, of course, Like, imagine, santol. Santol, especially santol. I have had a patient before that actually ate the santol seeds. I don't know why he swallowed those seeds, but it caused an obstruction, and I really don't know why he had to eat santol seeds. I don't know. Why would you eat seeds that big? weird. Is the stapler single use? Yes. You can reload it. You can you can reload it, and it's only one use. That's why you gotta make sure that when you use it, you do it right. Yeah. Okay. So you had another surgery when that happened. I think so. If you have an obstruction, you gotta get another surgery for it. So I hope this patient is going to do well. I'll keep you guys posted, I guess. I'm definitely watching over this patient, so if he needs anything after surgery, I'll probably have to help him out with a TPN after the surgery, because he'll need it at least 4 days after his surgery. He'd still need TPN, and we're really the funds of this patient, it's really depleting, so I'll probably be using more of the donations. So anyway, yeah, that's it. Okay. That's all. Thank you everyone for watching my stream. I'm sorry again, I started late. I fell asleep and I was supposed to nap for like 3 minutes and I ended up napping for like 30 minutes instead. Or actually more than 30. I think it was more than 30. So, yeah. Also, yeah, for those who just got here, those who are new to my content, I stream regularly. I stream more on Twitch. So, aside from doing medical education streams like this one, I also stream a variety of games. Sometimes I do karaoke, sometimes I do random chatting streams, mostly on Twitch. I use YouTube for like my medical education streams and for like highlights. And if I feel what do you call this? If I feel like it, I'd post VODs. Usually I just post the VODs of collabs now. So yeah. So I'm gonna be using two. Yeah, actually, the stapler, the stapler that we got for the patient has 2 loads. Okay, so we can use it twice. It's just enough for resecting the stomach, the part of the stomach that needs to be resected, and then we'll probably just do the anastomosis by hand. Okay. Now I'm having second thought if by lechon is paid, I haven't eaten since New Year. Go eat your lechon, no, man. Lechon, it's not like you eat lechon every day. I mean, lechon is good. I mean, you don't eat it every day. That should be fine. You just eat it like on occasions. That's fine. It's a different story if you like eat it every day. Then that's something. It's like you have money. You're rich that you can eat it every day, and then you're rich and unhealthy. That's basically what it means to eat lechon every day. Anyway, yeah. Lots of fun, everybody. Thank you for coming to my stream. I'll be streaming again on, when is my next stream? I forgot my own stream schedule. I always forget my own stream schedule. I make a stream schedule and then I forget. I have to actually look at it just to know. My next stream is on Thursday. I'll be streaming on Twitch. I'll be playing Diablo 4. And also on Saturday, Diablo 4. Alright, so thank you very much. I hope you guys learned a lot, and I really hope this patient will do well. Okay, I'll keep you guys posted on Twitter and on Facebook. Okay? Yeah, Atsupan, thank you so much. Bye-bye, and good night, everybody. Good night. Bye-bye. Bye.